Hi, everybody. Thank you so much for the opportunity to present. I'm thrilled to be here and to discuss our topic, the effect of parathyroidectomy on the development of depression among adults with primary hyperparathyroidism. We have no commercial disclosures. So primary hyperparathyroidism is a common disorder of aging and often associated with neuropsychiatric symptoms such as depression. We know that the only definitive treatment for primary hyperparathyroidism is surgery with parathyroidectomy. And this actually can commonly improve symptoms of depression and its associated symptoms. But what we don't know is if parathyroidectomy can prevent the development of these neuropsychiatric symptoms among patients with primary hyperparathyroidism. So in this context, we aim to evaluate the effect of early parathyroidectomy on the incidence of new depression among patients with primary hyperparathyroidism, with the aim of informing preoperative decision-making. We used a newer causal inference method called target trial emulation, which uses observational data and aims to replicate a randomized controlled trial. We used VA claims data from 2000 to 2019 with strict inclusion and exclusion criteria, with the goal of replicating and only including patients that would be included with a randomized control trial. We then emulated a randomized trial and examined parathyroidectomy within 1 year of diagnosis compared to non-operative management for primary hyperparathyroidism, with our main outcome being the development of new depression. Target trial emulation uses advanced biostatistical methods on observational data, really to replicate these results that we get from a randomized trial. And we do this in a few different ways. The first part of that process is cloning in order to account for mortal time bias. And then we also use censoring and inverse probability of censoring weights in order to address confounding. With these two methods, we performed an extended Cox model in order to determine the effect of early parathyroidectomy on the development of depression compared to non-operative management. We also performed a pre-specified subgroup analysis of older and younger adults in order to evaluate for heterogeneity of the treatment effect. Here's a brief excerpt of our cohort. You can see that there was already over 40,000 patients included. The cohort was predominantly male, but this was equivalent across both groups. And as you may expect, the parathyroidectomy group was overall younger, had a more severe biochemical profile, and was overall healthier with a lower rate of comorbidities. So in light of these differences, we examined standardized mean differences of the covariates and used inverse probability weights to account for them. So you can see prior to weighting, marked in black here, the standardized mean differences were quite high in the covariates. But after inverse probability weighting, they were all less than 1, marked in red, which indicates good balance among the treatment groups. Thank you. So in our population, the overall rate of depression was 12%. And then at 5 years, between the parathyroidectomy group and non-operative management, you can see it was 11% compared to 9%. At 10 years, those incidences converged and were both 18%. This displayed another way, you can see the cumulative incidence of depression over time really is overlapping at every time point that we followed that. So our primary analysis, we found no difference in the adjusted rate of new depression in these patients managed with parathyroidectomy compared to non-operative management. You can see this with the confidence interval overlapping 1. And then when we examined our pre-specified age groups of less than 65 and over than 65, we found similar results, that there was, and this indicating that there's no heterogeneity of our treatment effect here. So these results are somewhat in contrast to a growing body of work that indicates that parathyroidectomy can improve the symptoms of depression among adults with primary hyperparathyroidism. I think there are a few possible explanations for these results. It could be that primary hyperparathyroidism exacerbates these underlying risk factors of depression, results in possibly a more pronounced presentation, but treatment with parathyroidectomy is not a strong enough effect to mitigate all those risk factors. It could also be that the overall rate of incident depression is not affected by surgery, but the symptoms themselves, the severity is lessened with treatment, and that's just not captured with our definition of depression. And then finally, it may be that these neurocognitive effects of parathyroidectomy, depression, its associated symptoms are really better captured outside of claims data and something that in quality of life measures or functional status. So this study is not without limitations. The first being the gender breakdown of our study. It was predominantly male, which we would expect with a VA population, but we used a large and diverse cohort, and so we would not expect that to affect our results too much. And then also, although we used a validated definition of depression, there's a possibility that there was patients with undiagnosed depression included in the cohort. However, we would expect that to be equal across both groups and not affect our results. So overall, we used an emulated target trial of a large cohort of patients with primary hyperparathyroidism and found that early parathyroidectomy had no effect on the development of depression compared to non-operative management. I think that these findings are relevant to preoperative discussions, especially among adults or patients who may be of higher risk to undergo surgery. We know that there are many benefits to parathyroidectomy, especially in certain populations of patients in regards to bone health, fracture risk reduction. However, it's important for our recommendations to remain evidence-based because data has been shown that there's a benefit to patients in reduction of depression symptoms. It's very easy to extrapolate that we could prevent depression with parathyroidectomy. And based on these results, we would say that overall the prevention of depression should not be a key consideration in the decision to undergo surgery. Thank you all for the opportunity to present and to a great team.